My name is Dr. Antoni, and I'd like to speak with you about transforaminal epidural steroid injections. Transforaminal epidural steroid injections are a minimally invasive treatment used to treat radiculopathy. Radiculopathy is just a fancy word for pinched nerve, a pinched nerve that sends pain down the leg. Most people are familiar with the term sciatica. Sciatica is also another term for radiculopathy. Sciatica can be caused by mechanical compression of the nerve, a disc, a bone spur, thickened soft tissues that can compress the nerve, or it can be caused by chemical irritation of the nerve, or chemical radiculopathy. The disc is made up of two components, the outer leather-like covering called the annulus fibrosus, and the inner crab meat-like material called the nucleus pulposus. The leather, or annulus fibrosus, is inert and doesn't bother the nerve roots very much. If it did, everyone would have pain all the time because your nerves are in constant contact with your annulus fibrosus. But when your leather covering becomes cracked or ruptured, and the inner core of the disc, called the nucleus pulposus, can leak out, or its chemicals can leak out, called cytokines, which are very irritative and inflammatory, this can cause pain. Again, not necessarily from the compression of a disc, but just from these chemicals leaking out on the nerve. But most commonly, people are familiar with a pinched nerve. That is a disc herniation or a disc bulge that's mechanically squeezing on the nerve and causing pain. This is the primary indication or use for a transforaminal epidural steroid injection. Oftentimes, people will treat back pain with an epidural steroid injection as well. The thinking is that putting the soothing medication, which is steroid, can decrease the inflammatory response from that very inflamed and irritated disc from the cytokines. It doesn't always work, but it's definitely a better option than surgery. And if it works even in just a small number of people, it's still worth trying if you can avoid an open surgical procedure. But again, the primary reason to have a transforaminal epidural steroid injection is for leg pain, sciatica, radiculopathy, pinched nerve, whatever you want to call it. This is a lumbar spine. To give you your orientation, if this were in my body, it'd be positioned in this way, down in the lumbar area. This is the front, this is the left side, this is the right side, and this is the back. Epidural steroid injections are given in three typical ways. One is an interlaminar epidural steroid injection, where the needle is placed between the bones in the midline, called the lamina. The medication is dispersed in a more of a shotgun fashion, if you will. That is, the medication is allowed to disperse and affect all of the nerves, and these can be effective. Another type of epidural steroid injection is called a caudal, and this is actually very useful in a patient that has previous surgery. It's difficult to access the nerve roots due to scar tissue, etc. A caudal is done by placing a needle in what's called the caudal foramen, and it also has a reduced chance of dural puncture, as previously discussed in these videos by Dr. Zars. The way that we do our epidural steroid injections is via a method called the transforaminal epidural steroid injection. This has been shown in clinical research to be the most effective way to provide relief, both short-term and long-term, as well as be able to identify the specific level that is responsible for the pain. And the way we do this is we rotate the fluoroscope such that we are looking straight down the tunnel or the foramen that the nerve exits, so that we can place our needle just above where we expect the nerve to be. Again, that's where we expect it to be. Sometimes the nerve can be pushed up or down by a disc or a bone spur, and we can't see the nerves on x-ray. All we can see is the bones. But we put the needle where we expect the nerve not to be located so that we don't put a needle in the nerve. Surprisingly, it's actually not a big problem, except that it hurts, if we place the needle into the nerve. As long as the needle goes in and out, it's very unlikely to cause pain for very long and very, very unlikely to cause any damage. The real problem is if the needle goes into the meat of the nerve and then we continue to inject material such as lidocaine or any other anesthetic or steroid into the meat of that nerve. That can cause permanent damage to the nerve. And again, this is the reason why it's so important that you are awake enough to communicate with us even though you're receiving conscious sedation. And you can refer to our conscious sedation video to learn more about that. Once this medication has been deposited, the local anesthetic will oftentimes provide relief immediately, and the steroid will typically kick in 24 to 48 hours, and in some cases provide very long-term relief. It's very common for a patient to undergo a series of 3 epidural steroid injections. These can be spaced up 2 weeks apart, up to 6 weeks apart. A very common spacing is 2 to 4 weeks. And the thinking here is that as long as the initial epidural steroid injection was effective, with each additional administration of steroid medication, we decrease the inflammation of that nerve more and more with each additional injection. The thing also to understand is that if you have what's called foraminal stenosis, whether it's from a bone spur, a disc herniation that's pressing on the nerve, or thickened soft tissue such as something called ligamentum flavum, the size of the tunnel is not going to be made larger by doing a transforaminal epidural steroid injection or any epidural steroid injection. What we're doing is decreasing the inflammation in the nerve itself and causing the nerve to essentially shrink down as it becomes de-inflamed and thereby create more room for the nerve. The only way to open up that space is to do a surgical procedure, and there are a number of surgical procedures that can be offered, anywhere from minimally invasive discectomies all the way up to full-blown open fusion surgeries. But the bottom line is this is not opening up that space. This is simply taking the inflammation out of the nerve and, in theory, out of the disc as well that may be irritating that nerve. In some cases, when you get your epidural steroid injection, you may not feel immediate relief. The steroid can take 24 to 48 hours to kick in, and sometimes even longer. I've had patients tell me that they didn't feel much relief for almost a week, and then suddenly the relief kicked in. Some patients feel relief almost immediately. The point being, don't be discouraged if you don't feel immediate relief. If, however, you haven't felt relief by 7 days, then it's likely that the epidural steroid injection is not going to be effective in your case. It's very important, if you're going to undergo an epidural steroid injection, that you notify us of the following things. We need to know if you're on a blood thinner, number 1. A baby aspirin or even a 325 milligram aspirin is no longer considered a problem. It once was. But we've now determined that both aspirin as well as other non-steroidal anti-inflammatories are really not a problem and do not pose a risk. However, drugs like Coumadin, Plavix, Xarelto, or other drugs that are taken for cardiac reasons or that are taken for postoperative DVT prophylaxis, those drugs are a problem. And either you have to wait until you no longer need that drug, or if you are in a safe, if it is a safe time to take you off the drug, you will have to be taken off the drug an appropriate time before the injection. Plavix typically needs to be stopped 5 days prior to your procedure. Coumadin needs to be stopped based on what your level is, and so you'll have to have your INR checked. In our office, we're very uncomfortable doing a procedure on someone, especially around the nerves, if you have an INR of greater than 1.5. Also, if you're a diabetic, it's very important to understand that you may have erratic blood sugars or a spike in your blood sugar for 24 to 48 hours after the injection. Although the steroid that we put in is more of a local injection, it's not like the kind that goes into a muscle or a pill that goes in the mouth. Certainly some of that medication will bleed into your vascular system, and as you know, or if you're a diabetic, you probably realize that steroids can cause your blood sugar to go haywire. So it's very important to closely monitor your blood sugar with your Accuchecks after your injection, and if you are having difficulty controlling it, you need to contact us or your primary care doctor. So in conclusion, epidural steroid injections are a minimally invasive, outpatient, very effective treatment for people who have sciatica or leg pain, and also for some patients who have back pain. This is a great way to try to avoid surgery. And if your epidural steroid injection is not effective, you haven't burnt any bridges. You can still have surgery if that's what needs to happen. So if you are having any leg pain or even back pain, be sure to talk to us about how an epidural steroid injection may be the right treatment for you.